COVID-19 monthly webinar series. Today's session is in partnership with the Consortium of University for Global Health, in short CUGH. This is an unprecedented pandemic which will require a contribution for all of us. My name is Nachega. I am an adjunct professor of medicine and director of the Center for Infectious Disease at Stellenbosch University in Cape Town, South Africa, where I have my base of research and teaching operations. I hold my primary appointment within the Department of Epidemiology at University of Pittsburgh as an associate professor of epidemiology, infectious diseases, and microbiology. Let me have my co-moderator introduce himself and brief you on few webinar housekeeping issues.
Yeah, hi, my name is Quentin Eichbaum. I'm a professor of pathology, microbiology, and immunology at Vanderbilt University, and also professor of medical education. And I work with various global health groups, including the CUGH. And I'm going to be co-moderating this with Jean Nachega. I am a native of Africa, having been born and raised in Namibia, so I understand the continent fairly well. Just a couple of housekeeping things. We ask everyone not to use video because that takes up unnecessary bandwidth. Secondly, you will probably be muted while the speakers are on because that creates too much disturbance. I will be monitoring the questions, and there's a chat box, as you can see in the Zoom platform, in which you can send your questions to me. It's on the bottom right-hand side, and we'll try to get to as many questions as we can at the end, and may have to bundle some of them. But please, this is meant to be answer many people's questions and concerns, and I hope we get through the talks in time. There are 3 talks, which should be each of 10 minutes. And with that, I will hand the mic back to Dr. Nachega.
Thank you. Without further ado, let me introduce our first speaker. If Wolfgang, you can share your slides. So Professor Wolfgang Preiser is a professor of medical virology at Stellenbosch University, and also he heads the department, and he been involved in the task force of the response to COVID-19 at South African level, and he is one of the experts of SARS that we've been able to face some time ago. So with further ado, let me have Wolfgang his first talk. Wolfgang.
Thank you very much, John, and good afternoon to everybody. This is really exciting, this endeavor. I will be talking very briefly about the virus, a bit of the epidemiology of COVID-19, and a word on testing. And this is just a reminder of how it all started in early December of last year. Unusual cases of pneumonia were noted in Wuhan in China, and any of the common etiologies were not found. So, and then everything happened rapidly. Within a few weeks, a new coronavirus had been identified. At the end of December, the Chinese authorities alerted WHO and the international community that there was an outbreak ongoing. There is this story of the market that was shut down as early cases were linked to it. And then just a week later, the new virus and the first tests to look for this virus in patient specimens became available. And this is where we are now, and so it just gives an impression of how rapidly this has been evolving. It's 180,000 cases as of yesterday and 7,500 deaths. And you see that China, which used to be which is the epicenter of the outbreak, more cases are now actually occurring in other countries, so outside of China. So this whole epidemiology has shifted, and you see that in the curve here. There are some significant developments. So at the end of January, WHO declared a public health emergency of international concern. And they were hesitant to call it a pandemic until recently. So just a week ago, it was declared a pandemic officially. And all these things have certain implications as to what countries are supposed and are allowed to do in order to protect themselves and their populations. But what you also see is this massive surge in China, and these nits here in the curve are due to change criteria for reporting. But what's really important is to see here, to look at the curves in Iran and Italy, South Korea, and the United States and Taiwan. And some countries affected early, like Taiwan, Singapore, and South Korea, actually managed their outbreaks so well that it was contained. Whereas others, Italy, Iran, and as of late also the United States of America, took measures too late, usually a mixture of late recognition and then delayed measures to contain it. So at my age, and having been involved with the SARS outbreak in 2003, my first question is this SARS reloaded? And actually the name of the virus suggests, and rightly so, that the new virus is closely related to the SARS virus of 2003. This was early 2003 in Guangdong, and what then happened is that a doctor from Guangdong went to Hong Kong and there unwittingly infected a number of other people who returned to their respective home countries, and what ensued was a worldwide spread. And this is where I got involved, working in Frankfurt, Germany at the time. This is the German index patient, the doctor from Singapore, taking off the plane. And what we did, and it all took a bit longer than it does these days, we were able to isolate the virus on cell culture, that's top right here. In the supernatant of the culture, we looked at it by electron microscopy, and then colleagues of ours in Hamburg amplified the genome by broadly reactive PCRs and sequenced it, and found that this is a coronavirus that had not previously been described from either human beings or animals. So there's a number of important questions that arise from such findings. Firstly, where does it come from? You need to know it and then try to control that. And secondly, how does it spread? What proportion of cases arise from exposure to the source, the index cases? How many from onward transmission, human to human? Route of transmission, where does it happen, in households, healthcare, elsewhere? And who is infectious? Would people with asymptomatic infection also be infectious? So I had the pleasure at the time to join, this is me in younger years, a WHO commission to delegation to China, and we learned about early index cases in Guangdong province. And the interesting thing is that these cases that constitute the first of various smaller and bigger outbreaks, they all had links to animal markets or kitchens. So they were exposed to wild animals. And that is, of course, a very important lead, and subsequent investigations in animals on such markets revealed that the extremely closely related virus was circulating in them. And that had obviously been the source of the human infections, of a few human infections that were then subsequently spread through human to human spread. And at the time, there was a clampdown on the animal markets. The good news is that SARS could be brought to an end, and it was really traditional sanitary measures. The fancy medical advancements did not really play a role here. And there were some setbacks due to delayed recognition of cases and some super spreading events. But in the end, you see the numbers here. They have long been surpassed by the current outbreak. The bad news at the time was that the fatality rate was almost 10%, which is, of course, a lot higher than what we are seeing now. And subsequent research, coronaviruses then became very attractive things to study in a number of scientific studies. So we learned afterwards that there's a whole host of different coronaviruses hosted by different bats, and including the predecessors of the SARS coronavirus from 2003, and also our new coronavirus, SARS-CoV-2. There was another coronavirus in between in 2012. It became first known in the Middle East. And again, a new coronavirus caused another respiratory and very dangerous disease. There is a link to camels. Humans become infected from camels. The original source of the virus is also thought to be in bats. And subsequent investigations revealed that this virus has been around in camels for a long time. Old samples were tested, but only then at the time in 2012 was it identified as a human pathogen. And that is interesting and makes you wonder why would it have been around, including in many places north of the equator in Africa, and why would not have human infections either not have occurred or maybe not. The difference between MERS and SARS-CoV-2 and COVID-19 is, of course, that MERS is a low-level ongoing zoonosis with cases acquiring infection from camels, and unless good healthcare infection control prevention measures are instituted, they will spread it to household contacts and in hospitals. And there were some dramatic outbreaks, including the red curve here, which is from Korea. But otherwise, since these things have been strengthened, there continue to be a trickle of cases, but it's not taking off. So SARS never made it beyond limited human-to-human spread, and the same is luckily true for MERS. But unfortunately, our new SARS-CoV-2 unfortunately has taken that barrier and has firmly established itself within the human population by now. So, and this is what you can do with the amazing tools that modern epidemiology and molecular virology offers. So there's a number of isolates and a number of sequences so on. We can place it very well on the family tree of the coronaviruses, even though we don't know what the source was directly. So up to early January, we knew of 4 human coronaviruses. And those two, the first two here, OC43-229E, they have been around since the 1960s. In fact, they have been around, of course, for much longer, for decades or centuries, but they were detected in the 1960s. And then they were almost forgotten by the medical virology community, being agents of common cold diseases, not really worth testing for. And after SARS, when there was a renewed interest in coronaviruses, another 2 coronaviruses were discovered, both of them also very common in humankind around the world, again, mostly causing trivial common cold-like diseases, very rarely more severe disease presentations. And that is also, it shows that if you look, you will find. And interestingly, those 2 have also been around for decades, if not longer. So they are not new, they are only newly discovered. And then we have those 2 nasty ones that I briefly reported about, SARS-CoV, which was contained in 2002 and 3 and is no longer seen in humans. It does not circulate. And MERS coronavirus since 2012. It does not really circulate in humans, but there is ongoing occasional introduction from an animal reservoir into human beings. And now we have our new coronavirus, SARS-CoV-2, and we don't really know which of the 2 groups it's going to join. Its mortality is a lot lower than SARS and particularly MERS, with almost 30% of people who will die from it. But of course, it's a lot higher than from these well-adapted, long-standing human coronaviruses. So that is something that remains to be seen, how it will behave in the long term. So looking at our 2 questions again, firstly, the source, we know for sure it's an animal species, lots of related viruses in different bats. We think there must be an intermediary host involved because few viruses are able to spread directly from bats to human beings. Pangolins are certainly top contenders for this. There are some papers out, but they need to be confirmed with further and additional studies. And of course, the one sad thing about this is that since 2003, at the latest, we knew about the risks that these animal markets and the animal trade in general of wild animal species, that the risks that they pose. And yet they were allowed to resume, and they allowed ongoing speed dating, as it has been named, of viruses. And now, after almost 20 years, another human pathogen came out of this, which is very sad. It's a missed opportunity. The good news is, of course, that at this stage, this is an entirely human-to-human pandemic. So the animal source is of academic interest and for preventing future outbreaks, but it's not something that we need to worry about urgently now. And this is sort of a picture that symbolizes both. Does it spread via respiratory droplet secretions? Only under special situations like in ICUs, intubated patients, do we think that aerosols would play a role. That is a big difference because aerosols are much more difficult to control than droplet secretions. We know of household and nosocomial transmissions of SARS-CoV-2. We know that people may be infectious before onset of symptoms. We don't know for sure how long they will remain infectious. We do know that asymptomatic infections occur, but we do not know their overall role that they play in transmission, whether they are epidemiologically important or not. And of course, we have a gigantic experiment underway now on a global scale, and that is, will social distancing in its various versions mitigate the pandemic? And the important thing here is you need to start early. If any day or 2 days of delay will double your cases, so early on. And that picture shows it, which does not currently now move. Well, it was supposed to move. And this is what we all fear. And this is what the current mitigation game is all about. We want to avoid this early peak of cases, including the severe, clinically severe cases, which would be 20% of those infected. And that would also be where you see your 2% or so of mortality. We want to flatten the curve, to spread it out here, and to give the health system a better chance of treating those patients optimally. This is what this whole mitigation that we're currently doing is all about. And this is where the virus sits in comparison to other viruses. Measles, extremely contagious, not very deadly. Bird flu, Ebola, extremely deadly, but not very contagious. So the R naught is not so high. And this is where we think our new virus will sit. So it's in between, and that is probably on one hand good news. On the other hand, it probably also means this is what makes it so difficult to control. My personal speculation has been for some time, and I think it's moving this way, that we are actually seeing the early times of what will become just another human respiratory pathogens. It is not so virulent. There may be infectiousness before onset of symptoms or when people are entirely asymptomatic, and it's obviously quite good at human-to-human transmission. And time will tell, but I would not be surprised if in 10 years' time, this would have just joined the ranks of our normal seasonal, perhaps, respiratory pathogens. Now about Africa. You can't see Africa really on this curve. It's hiding down here. Now, does that mean we are off the... Unfortunately, we are not. It probably just means that Africa is lucky in being late. Now, why would that be? So the hotspots that we've seen so far, China, Korea, Iran, Italy, are all in the northern hemisphere, so they're currently in their winter season, and we know that many respiratory viruses are much more easily transmitted in winter with low ambient temperatures. It could be that SARS-CoV-2 will follow the same pattern. We don't know for sure, but if that is the case, we are heading for difficult times, because the southern hemisphere is now heading for their autumn and winter season. So if anything, it is going to get worse. And this is why we have really been advocating that this year, of all years, people should be vaccinated against seasonal influenza. Both healthcare workers, because their workforce will be needed in full strength, because we don't want them to infect other patients, and also risk patients, because we don't want them to be mistaken for COVID-19 cases. There is another big problem, and that is that we don't really know very well on what comorbidity with HIV or TB and other conditions prevalent in Africa will mean for COVID-19. We have a bit of information on diabetes and other chronic diseases, and they have a bad influence. They are a risk factor for severe COVID-19 and for death. And one can only assume at this stage that HIV and or TB co-infection will play a similar role, but one doesn't know for sure. So in conclusion, a pandemic is happening currently. Many wealthy countries are struggling, and that offers some consolation in a way to Africa, but it should not lead to a false sense of security. The good thing is we can learn from them. We can watch them, because our epidemic curve is behind by a few weeks, but we must brace for being engulfed by COVID like much of the rest of the world has been. And we need to think and work very smart. Our resources are limited as is, and if we can prevent it, that is of course a lot better than cure. So we need to really have well-planned and executed prevention strategies. And I'm very glad to say that in South Africa, the President called for a state of emergency last week on Sunday, and drastic measures have been taken that will do enormous damage to the economy and livelihoods, but on the other hand, are hoped to help save many tens of thousands of lives. Thank you very much.
Thank you very much, Professor Preiser. So in interest of time, we're gonna move to the next speaker. Dr. Lake is replacing Professor Seydi from the Senegal team. So this is the team that has been on forefront, the first one in Africa to deal with coronavirus disease patient. So I go ahead, Dr. Lake.
Well, thank you very much. Oh, are you hearing me?
Yes.
Okay, so thank you very much for inviting us for this meeting. Also, as you say, I will speak on behalf of Professor Seydi, who is currently not available. He's in a meeting in the Ministry of Health. So we are very glad to be invited by the AFREhealth to this webinar to present the Senegalese experience for this COVID-19. And we will share with you the epidemiologic and clinical presentations and the outcomes. As the previous speakers said, Africa entered the epidemic very later than the others. But in our country, since January, we were in a preparedness phases, and we entered the response phase on February 27th, and with our first imported case. As he said, our most challenge was the importing cases that was coming from the hotspots that are here in the European countries. And for the case definition here, we have used the case definition that has provided by WHO and
Excuse me, Dr. Lake, could you
yes?
put on a slideshow?
Okay.
Mode?
Sorry.
No problem.
Is it okay?
No problem. Yeah.
Okay. So the case definition that we use is the one that was given, it was provided by WHO, and the latest one. And we have here a laboratory of reference, which is Institut Pasteur of Dakar. And as the other countries, the testing was done by RT-PCR on nasopharyngeal and oropharyngeal swabs. So currently, we have, as of March 18, we have 37 cases, which 15 of them was imported cases. And here the hotspots of imported cases was France and also Italy. And we'll see that the other cases was from a secondary transmission from our index cases that was coming from Italy. And we'll see that a picture later and see how all these secondary cases were from a household acquisition. Today, there is no documented community transmission. That's what we can say. As I speak earlier, the first cases of COVID-19 occurred on the 27th of February, which was a French resident who was coming from holidays in France. And after 2 days after, we have 4 imported cases. And after a week of where there was no cases, the things was going up and growing till the 19th March that when we have our fifth cases. That was our Italian patient that was coming from Italy. And as we see in the country, we have 2 hotspots. Confirmed cases are from Dakar and mostly from Touba, which is a country, which is a city which is in the center of our country, and it has a specific cultural factor that it is a religious. Touba is a religious town, and all the household acquisition was coming from Touba. So what we can say for our 5th cases, it was a man who was coming from Italy, who arrived on 7 March, which he was asymptomatic. And 2 days after, he was experiencing some symptoms as coughing, fever, and he has sore throat. And so the day after, he was in a district center here in Touba, and the diagnostic was confirmed. what we can see when we were searching about the contact tracing, we see that he has 71 contacts, and among these 71 contacts, we have 14 healthcare workers. Fortunately, those healthcare workers till date are negative. But in his household, he has infected around 20, as of 18 March, he has infected 20 persons. As you see in this figure, you can see he has infected his spouses, his sons, his daughters, and also his niece, his sister, and it was around 20%. But all you can see in this picture is that there is a cluster of this transmission. But we have some fear regarding his daughter. What you can see is here the case number 12. His daughter has infected her companion who was a student. They were in the same cases. In the same class, sorry. So she infected her. What we are fearing that from this case 25, the student, that our greatest fear is that we'll have a second cluster. But till now, all the high risk contact of this student who was tested are negative. And it's the 5th day since she was diagnosed. And what the epidemiologic data of this confirmed cases shown is that most of our confirmed cases are women. It represents 2/3 of our patients. And what we see is that also the median age is 35 years, and it ranges to we have a baby of 2 months, and also the oldest one have 82 years old. And when you see the age distribution, you see that all our patients has mostly young adults. When we look about the clinical features, we were talking later about the asymptomatic patient. We see that on about the 30 patients, you see 7 of them was asymptomatic at the time of the diagnosis. And when the infection was symptomatic, fever represented only less than 40% of our patients. And the most symptom that we can see was cough, was also asthenia and headache. All cases were mild cases, so we are very fortunate for that. And till date, we don't experience severe cases such as pneumonia or RDS. But we have some patients that have comorbidities. We see that those patients are very high risk of mortality, especially those who has blood pressure, diabetes or asthma. When we have some of them, we have 2 who have high blood pressures and 2 who have diabetes. And so for those people, we have closely monitoring them to see if everyone is going okay or not. Till this day, everything is fine. So what is the treatment and outcome? So far, we have 31 patients admitted, and we have 2 patients who has recovered, cured, and discharged. Normally, at the end of this week, we will have more patients who has recovered. And as you see, so far we have only given to them a symptomatic treatment such as analgesic, vitamins, and when they have comorbidities, we are giving them the treatment of these comorbidities. But we are thinking about some investigational treatment. As you see these days, there is a French team who has some good results with treatment associating hydroxyplaquenil and azithromycin, and also other studies who are talking about good result with lopinavir and chloroquine. And now we are thinking on these patients, we will provide them hydroxyplaquenil. So what we can, in conclusion, what we can see in our patient is that we have mostly family acquisition, household acquisition from an imported cases who are coming from Italy, and we have 1 cluster who is currently very monitored. And also we have some patients coming from some hotspot countries such as France and Italy. So Dr. Wolfgang was talking about in Africa, it's better to have prevention is better. So till yesterday here in Senegal, the borders are closed. I think it will help from the people who are coming from the hotspots countries, but we don't know so far how many of them are here in the country. So we have to monitor that very closely. So, and also so far we have no disease, no patient disease to recover. So we will very closely monitor all these patients, and we will see what happens. So it's evident that Africa is affected, and Senegal, and we think that our patient will, the number of confirmed cases will grow these days, but we are here trying to manage all these factors and prevent and to privilege the prevention. So thank you very much for having me this and for inviting us. And I will want to acknowledge all the Ministry of Health of Senegal, and also the response team that is led by the group of EOC, the Emergency Operations Center, and also all the healthcare workers who are here in the country, in the field, trying to tackle this epidemic, and also for AFREhealth for inviting the infectious disease team here to share this data. Thank you very much, and sorry for my very bad English.
No, you did very well, Dr. Lake. Thank you so much. Let's move on. Professor Mehta, could you set up your slides? Thank you.
Okay.
Could I just ask everyone to turn off their video, the non-speakers, please? Thank you.
Hello, good afternoon. I'm Shaheen Mehta. I'm the past chair and founder of the Infection Control Africa Network, which operates in about 25 countries and now gone to 40. I'm a professor of infection control, retired from Stellenbosch University. So my remit today is very quickly and very briefly trying to condense the whole concept of infection control precautions, just by starting off to say that we, as we've already heard, started late. South Africa seems to be heading the league at the moment with 116 cases. I work with the Department of Health of South Africa, with the National Department of Health, and establishing a lot of the infection control programs, including the repatriation, a very successful repatriation of our 147 people back from Wuhan. So based on that, I think the main thing I'd like to address today is the panic and the fear. And some of the questions that we get through the hotline very clearly identifies the fact that people have got very short memories, or they think that this virus is worse than ever. So I'd like to actually just go through the very basics with everybody to remind them what is going on. I really apologize for making this thing so basic, but I think we have to go back to basics, particularly in Africa and in other countries indeed, where we are now running out of PPE and protective equipment, including the United Kingdom and the United States. We're running out of testing material, and very soon we're going to be running out of a lot of other things as well. So let's start off by saying what we need to remember, despite all the fake news and so on. The transmission is very clear from what Wolfgang has said, and also my other colleague from Senegal. It's droplet. And here, just for your information or to remind you, that these are the particles, the rather large droplets that fall to the ground within a meter. And as they dry up, they might go up to 1.5 meter, but that's about it. The rest of it is very clear in that it is directly touching your nose, touching your face, and hands-on surface and surface-to-face contact. Now, what's quite interesting is that today we keep reading about the aerosolization. There was a paper in the New England Journal, I think, talking about aerosolization, which I think had a lot of issues that had to be discussed. But the fact that we must remember is that there are no other routes of transmission that we know of, unless Wolfgang tells us differently at another time. So from a general point of view, what we've done from the South Africa, and I would like to actually give a huge compliment to our National Department of Health, including Minister Mkhize and the others, where they have come up with a very clear plan. And this is the infection control program for the public. They have provided alcohol-based hand rub and have insisted on frequent hand hygiene. Social spacing and distance is an important one. Cough etiquette is being followed. We have asked the over 70s to stay indoors to reduce exposure. Keeping the environment clean and dry, and of course the application of alcohol wipes that you can wipe down surfaces, particularly in the public areas and so on. When you're flushing your toilets, please keep the lid closed, because sometimes it's thought that viral particles may be viable in the beginning, particularly from the urine. And it's a possibility that if you keep looking into the toilet bowl, you might actually get yourself an infection. So if you are in a need to exercise, like indeed most of us want to, you can go out into an open, uncrowded park or space, or you can walk the dog, because that then, of course, in itself makes a lot of sense. The self-isolation program comes from the asymptomatic people coming off planes, very much like the Senegal story. And in this case, we have asked them to go and stay at home. You can have daily temperatures, and if there's any clinical flu-like symptoms, please tell us what's going on. Social distancing from other members of the family. This is 1.5 meters. However, if you want to eat with your family, you should sit at the far end of the table, and they could sit at this end, and that would give you 1.5 meters. We would prefer if you had separate bedrooms, but if you have to, in a condition where you cannot have a separate bedroom, I've advocated that you have beds laid out in a way that you're toe to toe, so that the largest distance at the 90-degree angle is more than 1.5 meters, 2 meters, depending on the length of the bed. You should have ventilation. The windows should be open and the door as well, so that you get lots of air and movement in that. If you want to go out for walks, that's fine. Avoid crowded areas, and of course we have the numbers. Now we are not testing asymptomatic or self-isolation unless they develop symptoms. If they do, then they will call a number, and they will await for somebody to come and see them. Then contact tracing kicks in, samples will be taken, and then if there is nothing going on for clinically for 14 days, it's absolutely fine. They can go on with their lives, and that will be good. I think it's really important. There's been a big discussion about why did the people who came back repatriated from Wuhan go up, and why were they isolated for 14 days, whereas the others are not, and so on. The reason was because they came from, at the time, a high-risk area. And so we had to isolate them and test them, and as you know, they were found to be negative. So if you're looking at IPC in the house, infection prevention in the house, clearly it's hand hygiene, cough etiquette, clean, dry environment. There's absolutely nothing different about this than you wouldn't do normally, apart from taking daily temperatures. If you're symptomatic but don't need to go to hospital, you can do the same. You can remain at home. The only difference might be that you might want to wear a surgical mask if you're leaving the room. And that is about it. If you have a designated caregiver in this situation, then we would like this person to be trained in how to look after you without getting infected themselves, bearing in mind the droplets are short. Again, here we have showing you very briefly to remind you of something you already know, which is that if you cover your mouth, you can reduce 50% of the infectious particles. And so that is the way we should be considering ourselves to go. These are the transmission-based precaution signs that we use at Tygerberg Hospital. It's contact precautions, which is hands, aprons or gloves, a door, and get rid of and discard your PPE. If you're applying droplet precautions, then you add a face mask. And now we come to something that is causing huge confusion amongst people, which is the difference between a face mask, surgical or medical, and an N95 respirator. We are suggesting that the only time you would need to use an N95 respirator is if you're going to be doing an aerosol generating procedure, very much the same and following the guidelines from the WHO. So to see a lot of people walking around the streets of South Africa or indeed even abroad in a hazmat suit and wearing N95 respirators makes no sense at all to us. We are a resource limited environment and we really need to conserve our resources the best we can. Moving to the healthcare worker, and there has been a lot of panic amongst the healthcare workers. There's also been panic amongst police forces, other groups, categories that come into contact with the population as to what to do and how to deal with this. But for the healthcare worker, we're looking at a patient looking after somebody would only have to be moderate illness. You wouldn't have a healthcare worker looking after anybody who's actually perfectly fit and well. In this case, we're looking at hand hygiene, surgical face mask with a shield, or you have goggles with the surgical face mask. We use plastic aprons because we really cannot afford a huge expensive output on gowns, particularly the water-resistant gowns, and we expect gloves. If the person is in a ventilated situation or they have aerosol-producing procedures, then we expect the healthcare workers to protect their mucous membranes from the mouth, the nose, and the eyes. And here again, the only difference will be that we will change them to an N95 respirator. A huge discussion at the moment, because of the shortages of such equipment, is can we reuse these? And maybe we can discuss that. Goggles, yes. Plastic aprons widely available. Fluid-resistant gowns if you must. But if you are bare below the elbows, it's quite easy for you to wipe down your arms afterwards with a bit of alcohol, and that should sort you out. Gloves, of course. So hand hygiene, I don't want to go into the details of this, but just suffice it to say, most of you around this table, I mean, around this discussion, will know the 5 moments of hand hygiene. And of course, we need to make sure that this is supplied in the healthcare facilities, as well as in the communal areas outside the healthcare, like retail shops and so on. All personnel worked in any way with direct people contact will want to clean their hands at the beginning, after, and after gloving and so on. Okay. I apologize for this, but I don't really think, this is the epitome, this sort of sums up absolutely everything we've talked about. So it's a given, or everybody will have hand hygiene. Your face cover will change from a surgical mask to an N95 if there is an aerosol generating procedure. And the reason I needed to do this was because we had to calculate the cost of PPE for each case inside and outside the healthcare facility. The body cover, we are very happy with aprons, and there's no evidence to say that it's not good enough, but some people feel very threatened and therefore they might want to wear a gown. Eye protection we would like to provide for those that are sneezing and coughing. Gloves, non-sterile of course, but not if you're self-isolating, and this is just here almost as a control for the rest of it. We definitely don't believe in head covers or foot covers, of course. Environmental cleaning will be daily wiped and wipe over with a disinfectant. If they are sneezing and coughing, then you can actually do that twice a day. So this is a major change that you need to really consider. And if it's an aerosol generating procedure, then please consider cleaning after each procedure and wipe over with disinfectant, because surfaces contaminated, as we read in the literature from Camp and others, can be for long term. They can be sometimes up to 9 to 10 days if we don't clean the surfaces properly. Therefore, the sooner we clean the surfaces, improve the procedure, and wipe over with the disinfectant, such as alcohol, and some people actually use chlorine. I really don't mind. You can use peracetic acid or hydrogen peroxide. The virus is sensitive to all that. You will actually be fine. The source from the distance from the source we know is 1 meter. Well, you can't actually deliver very good healthcare from a meter away, so you really have to. This doesn't apply. And of course, they can be distanced the other ways. Laundry, there's no need to do anything. There was a huge issue around burning all the laundry when we came back from Wuhan. The answer is no. Cutlery, crockery, absolutely not. Routine hot water. If you can put your hand in the water with the glove on, that is hot enough for you to wash and dry. And you don't need to disinfect it, and you don't need to do anything else to it. Healthcare waste, normal. Tissues in the bin. Aerosol generating will obviously land up in the infectious site, and that's about it. Temperatures as per protocol with daily records, and exercise, you can go where you like. But if you're coughing and sneezing and you don't want to go out, well, that's absolutely fine too. Just very quickly to show you why there's a big problem with shortages of masks is that the several layers of protective paper that is here changes the way fluid goes in. Now, I want to address this because there's stuff that's going on fake news, which says that if you use the blue side on the outside, then you protect others. And if you use the white side on the outside, then you protect yourself. And that is absolute rubbish. There's only one way of wearing this mask. There's the green bit on the outside, the white bit on the inside. Because of the layers the way they are, they will allow the movement of air through it. It is, however, a short-term barrier against the dispersal of large droplets, and many of the face covers are water resistant, but they become inefficient after a long usage. So maybe after about an hour to see what you want to do. And they are to be discarded after single use. They're not that expensive. And please do not buy cheap ones because they are completely useless. You might as well have two layers of tissue on your face in the meantime. This is a respirator, which is an N95 respirator that we use a lot in Africa, particularly South Africa, because of our TB situation. So for us, it's really important to preserve the N95 respirators, not for COVID-19, but for our TB cases and MDRs and XDRs in particular. So these are usually used, they used to be used for in industry to protect workers against toxic substances. However, now they're being used, we call FFP2 and 3 in Europe, but they are moderately water resistant, but they have loads of filters. So if I could just explain to you that there's a comfort layer, there's a filtration layer and so on, splash resistant layer, and there's a flexible nose piece. This, all it does actually reduce a lot of the particles. But don't forget that these actually are used for very small particles, 5 micrograms or less. Without going into too much detail, we do wear plastic aprons to prevent splashes, mainly worn for contact and droplet precautions in the presence of fluids, during damp cleaning, washing items, and so on. And you wear it in a way that all of you know, where you wear it on the outside and front, and when you take it off, you undo the taps on the back, you fold it on itself to make sure that your hands don't get recontaminated. Cotton gowns are not recommended because they're not water resistant, but if you insist on using them because you don't have anything else, then you can either wear a plastic apron inside or outside. Non-woven materials are really, really expensive. Some of them have waterproof layers on the arms and the front. And I'm not sure that we would use it in this situation, but we might, we obviously would need to do it if we've got an Ebola case or a viral hemorrhagic fever. So to my mind, these are not really recommended in COVID-19. This is certainly not recommended. This to me is a complete waste of time. There's no virus here that's going to jump up from this floor into this person's face. What they're spraying it with and why they're spraying it, I have no idea. But this person being sprayed, which is very reminiscent of Ebola, where we already published the damage to healthcare workers and other humans from chlorine, which is almost a 60% damage to the eyes, the respiratory tract, and the skin. Now, if we're looking at something that's affecting the respiratory tract, then the last thing you need is a chemical which is toxic, which is not allowed in the high-income countries at all, because it was used in the Second World War for gassing, for gas chambers, to be applied to people who already are respiratory challenged. So please remind yourself that this practice is not necessary, and that we are being the spread is through droplets. Very, very essential is communication with the public. It must be transparent, it must be open, and this is why I commend Minister Mkhize for making sure that every day somebody tells them exactly what's going on. We must make sure that despite what the press shows, everybody walking around in hazmats and covered from head to foot as though they're going to go into a really nasty Ebola outbreak. No, we don't approve of wearing hazmats. They shouldn't be there. No spraying of the environment and no applying of alcohol on gloves. That is really bad because the gloves will deteriorate under alcohol and they will open up the pores even further, allowing the virus to get to your hand. And if you're not very good at hand hygiene, you might land up touching your face and infecting yourself. The second thing is, of course, that you're going to have the same message for all groups. There should not be different messages coming from different areas. And we have done that. There is a very good system in South Africa where we coordinate all information going out. And of course, we have now got a situation which is very, very good for us, which said that we are not allowed all the fake news, home remedies, and other things that are found on the social media. If that is circulated, then the person might be liable to 6 months in prison, which I think is a very good idea. I don't want to run this video unless you actually want to. But if not, then you know exactly where it is and you can get it for yourself. And I think I've probably stayed within my time, and I thank you very much.
Thank you very much, Prof. Mehta. So I hand the moderation to Quentin. Quentin, could you take over?
Yeah.
We have about 15-minute Q&A.
Sure, right. So I'm monitoring questions both in the public chat box and some coming to me directly. So there's a string of questions about how good the evidence is for the treatment that was suggested by some French workers, and someone did send out a link that pertains to the azithromycin and lopinavir and chloroquine combinations, hydroclac and as well. I don't know if I got the combinations right, but I think it was probably addressed to Dr. Lake. There's a lot of interest in that. Hello?
Dr. Lake, you want to answer that question? Could we unmute the doctor?
Okay, so the French studies was done in a very small number of patients. It was 30, if I don't forget, it was 32. And among these patients, 24 of them received only hydroplaquenil and hydroxyplaquenil, and six patients was given the association hydroxyplaquenil and azithromycin. The results show that with patients with hydroxyplaquenil, they see at the day 6, there was a decrease of the clearance of the viral load clearance about 60% against the control. And when azithromycin and hydroxyplaquenil were was associated at day 6, they have 100% of viral load clearance. So what we see that there was not a very, it was not a very robust, maybe it's not a very robust studies, but in this time of experimentation, we here in Dakar, we think that we could use hydroxyplaquenil, and that's what we were planning to do for our patient and to see if it will work. The French paper will be published, I think, this week. They send us the paper. Maybe I can share it with you soon, so you can see the results.
Okay, thanks very much. So as I said, there's someone else provided a link as well, and would be glad if you could share that. Another question is, how well do patients respond to the are there recovered cases having any lung scarring or fibrosis? I think Preiser or Meta or anyone could answer that. Did you get the question? Are there recovered cases having any lung scarring or fibrosis?
Wolfgang Preiser here. I'm not a specialist on this. I have not seen any reports of sequelae, but I may have missed it. To be honest, I'm focusing on the virological and diagnostic stuff.
Sorry, this is Shaheen Mehta. I think there have been 2 papers published from China. One of them showing minimal scarring depending upon how early the patients were treated, and the other one showed that if they had a comorbidity, particularly if they were smokers, that the fibrosis was quite considerable. So they seem to be almost contradicting each other. Those are the only papers I've seen.
Okay. A question about whether it's premature, as is happening in China, to stop the isolation and let people mingle again, because there's some evidence with the Spanish flu that there was a second wave of infection, which was even worse. So does anyone think this is premature, or why are people confident about doing that? Maybe Dr. Mehta can take that, or Dr.
Thank you. Thank you very much. I think, look, we don't know enough about it, but having said the fact that they have stopped doing major draconian measures, they still are very, very cautious about the way they're behaving. In fact, I think many of you know that the Chinese did such a fantastic job that they have been invited to come to Italy to help with the Italian outbreak. So I think they might get a second wave, but it'll probably be like the ones that Wolfgang showed us. That was tall peaks and then much shorter peaks as we go along. My main concern is not that so much, but for Africa as we go into the summer, I mean, into the winter season. So I think that is a major issue.
Yeah. I believe that the UK seemed to have followed a strategy of letting it run in the general population, trying to protect the vulnerable, the elderly, and those with risk factors. But they have abandoned that apparently, and now sort of belatedly are instituting everybody else.
They have abandoned that, Wolfgang. They very much did that yesterday and today. So they're now jumping down the same wagon because their curve didn't flatten. and they suddenly got a high mortality in the intensive care units, and they ran out of bed. So my colleagues reliably informed me that they're going down the path of some of the other issues.
Yeah. And the sad thing is that with every day or days that you lose there, it will only be worse. So early measures are really of paramount importance. And I think it's far too early to speculate about what's going and how one should deal with this. This is an amazing global experiment, and one has to realize is what it is. I mean, shutting down the global economy in order to try and prevent the worst consequence of a new infectious disease, which is in fact not particularly bad as diseases go. But the problem is there are many of us, none of us is immune, and there are many of us who fall into one of the risk categories, and it is those people that we want to protect. It's amazing, and of course one has to argue, is the immense economic damage worth the effort? But if you don't do these efforts, one may end up with situations like is reported from Italy, where there are not enough respirators, and they have to choose whom to keep alive and whom not, and that would be many times worse in Africa. So I think it is really it's an all-out effort. Nobody knows whether it's going to work. In Africa, we are in the positive situation of being able to observe the international scene with a few weeks delay, and hopefully be able to assess, these measures are used, those are not, and then try to adapt our own response.
So we've got lots and lots of questions coming in, so you can give somewhat short answers. There's a set of questions about the age distribution. Maybe Dr. Lake, you presented evidence in Senegal that the age was younger than what we tend to be suggesting in Western countries. Do the speakers think we don't have a good handle on this yet, or is it still primarily infecting the aged? I think the evidence from Senegal presented showing a younger age distribution, and might that be of relevance to Africa, where the general demographics show a younger age overall compared to, say, Italy?
She's not muted.
Maybe she's muted. Dr. Preiser or Shaheen, do you want to comment on the age distribution?
I personally cannot make a big thing, because we don't have, most of our patients are young, sort of middle-aged. We've only had one neonate that got infected, and the others have all been very, in fact, quite sprightly, because the outbreak that started in South Africa started with a skiing party of 10 that returned from Italy, as you know. So all of them were under the age of 35 or 45, sorry. Okay. There have been 2 cases that we know of where they were over the age of 60. Both of them were foreigners who came into to the country and then subsequently developed infection. Neither of them is in intensive care. So I must touch wood and say that we have not had any people in the intensive care just yet. Because, as you said, the prevention cure thing. But having said that, we don't see this distribution of young children. But we might. I mean, I don't know what we're going to see later. But at the moment, it's just the bits in the middle, as the women, the age that she showed, where the middle age, not the middle age, but the young adult was being affected, similar to ours.
Okay. Do we have any evidence, just want to move on quickly, do we have any evidence that of immunity for people who have been infected with COVID-19?
So far, we don't have that. The test was ongoing by the Pasteur Institute in Dakar. So I think in these days we will see, if they provide us the results, what is their real immunity. But for every patient, we are doing the swabs and also blood testing for the serology. So we'll have the results further results.
I think it is. Sorry, I think it is safe to assume that once one has survived infection, one will be immune for a considerable period of time. In analogy to many other infectious diseases, there was one report of a presumed reinfection, but I think most people believe that what happened is that there was a false negative PCR result in between, and the subsequent one was positive again. So those, that would be very unusual, and so I think we can assume that you only get this once.
Yeah. Right. I think we've still got a couple of minutes. Let me try and select some questions here. Do we have any information about HIV and COVID-19 co-infection or risks, additional risks, especially given the high infection rate in South Africa? Are they at greater risk at all? Hard to establish at this early stage, but.
So far here in Senegal, in our patient, we didn't have association with HIV or TB, so I can give you a clear answer about that.
Okay. Anyone else? Let's see. For travelers or people who have been in contact with COVID-19 positive patients who are self-isolated and do not develop symptoms within 14 days, what is the risk of COVID-19 being COVID-19 positive when they return to work? I think the thing is somewhat arbitrary, but anyway, Dr. Mehta.
Thank you. Well, that's good, isn't it? That's exactly what we want to see. We want to see them sitting there for 14 days, contemplating the holiday they had, and then go back to work. And I must say that we're not going to test them, and we're not going to look for trouble where there isn't any. And that's it.
Question
point
about...
of, sorry, that's the point of the 2 weeks quarantine. If you do not develop illness during that time, you have not been infected and you can safely return to work.
Yes.
Yeah.
And there's no test that would done, and that is a problem. We come up here in our diagnostic lab all the time, tested and then think they can be released from quarantine. But there is no such thing. We cannot prove you non-infected by a negative test result, because as long as you're still in the incubation period, you could be developing infectiousness the following day and symptoms 2 days later. And so the negative test result is a picture of the moment. It does not help in any way with shortening the quarantine period. It's 2 weeks.
I see. Okay. Testing kits in Africa, what is the availability and where are they coming from? And United States is a huge shortage. So.
If I may answer as the diagnostic virologist here, in South Africa we are doing quite well so far, but we are already up into constraints, and we are of course competing with resource rich countries. There is a general shortage of test kits in the world. And in fact, it's not only the test kits in the lab, it's even the swabs. I mean, even America is desperately short of swabs to take specimens. And of course, we've all heard about the masks being sold out. So there is an enormous supply problem, even with relatively primitive things that are needed to combat the outbreak. And testing is firstly a question of supplies of diagnostics, and secondly, of course, one of manpower. So we've set up our own in-house assay here at Tygerberg, which we are using when our commercial suppliers are delivering their kits that we ordered. We are using that, but of course, staff are very limited. So it's a big problem, and it's a big problem anywhere in the world where people know they should be testing more, but they can't. And the worst example is certainly the United States, who for various reasons delayed the response, and we're sitting on community transmission of COVID and not noticing for several weeks.
But where are the kits in South Africa or elsewhere coming from? Are they developed from? Are they from China or developed?
Yeah, we are using a test kit from a Korean manufacturer, but the other diagnostic companies, the big names in the game, Roche and Abbott and Biosystems, they're all busy developing their own test kits, all of whom are, of course, at this stage for not for diagnostic use. We know that, and we can't help it, given the enormous urgency and the short timeline. But there are more and more manufacturers coming on board, and what's very important is every lab needs to choose their test according to the equipment that they have. So that it's it's one thing, looking at the tests and comparing parameters, but if you have this piece of equipment that you can use, or maybe using already for other purposes, and then a COVID test becomes available for that, that is of course what you're going to use. So it's a mixture of what's available in terms of staff expertise and experience, equipment, and what's available on the market. But it is tricky. We are navigating very difficult terrain here. And I think they're working overtime, the diagnostic manufacturers, but they're struggling to meet demand.
Okay. So, Dr. Nachega, we're going 5 minutes after the hour already. Do we want to stop or continue?
No, I think we need to stop there, unless...
Sorry, can I just make a point, Jean, if you don't mind? There are lots of questions on infection control, which have come through on the chat, and I've just replied privately to them on the chat. One of the things is that will there be a recording of this, and the other one is what PPE is the minimum amount required and so on. And these are some very practical issues that we need to discuss because of the cost of PPE and also indeed the cost of protecting healthcare workers. So maybe there's another way that we can deal with these matters, because I think people are particularly curious and interested.
Well, I think we can take a decision here if the line is needed by AFREhealth for another call, or if you want to continue for a few more minutes, because I was just about to get to the question about minimum PPE. And I think we can make the slides available if the speakers agree, and we are recording the session, and I think that can also be made available.
So we're going to go... Yeah, we're going to choose for the second option. So this webinar will be posted on AFREhealth website, and we're going to share all the slides of the speaker, and they will be able to communicate with the speaker in private. And also, this is just one of many series, a monthly series of COVID webinar AFREhealth is sponsoring. So just stay tuned. Unfortunately, we have to stop here. Other people have a commitment. So I would like, on behalf again of AFREhealth President and Governing Council, to thank everyone. All the speakers did a terrific work, and all the participant questions were very timely on target. So again, this is a very challenging time, and we're gonna need really the collaboration, both global collaboration and local collaboration, to be able to getting all the skills together to be able to make a difference. So thank you very much. And Quentin, you want to a closing word?
No, I think just apologize for those whose questions that we didn't get to, but it's certainly sparked a lot of interest. And as Jean said, this is just the first of a series we hope to continue. And there were requests, as I don't think we mentioned yet, to do one in French and one in Portuguese, so for West Africa and the Lusophone countries. So that's also being planned up ahead.
Okay, thank you everyone. And keep safe and all your loved ones. Thank you very much.
Thank you. Bye.
Bye.